So back again, just want to make a small comment regarding having very complex formula, 2 divided by 2.72 or 2.7 times whatever length of your proximal. It's really simple, especially once you think about it, how much time you spend on deformity correction pre-planning. It takes a long time to pre-plan your deformity corrections and angles and all that stuff. So I think spending 2 minutes and applying maybe this method and seeing that it actually works, it would be good, because I'm not just saying because I tested on animals or rats. This has been tested by orthopedic surgeons who are good in their field, and they find it that if you do 2 over E times your proximal segment length, you actually can get away. You most likely won't fail even in some of these distal fractures, femoral fractures. So I think it's little time spent and you can have benefit and not have patient to come back and redo it again. So here, active control of motion. So I want to expand a little bit Alex's talk regarding that axial micromotion, and it is, and I agree with Alex. Alex, I agree with you. What I mean is axial micromotion. It means that moves that elastic in segment and kind of returns again with that segment, and that's what you want to build that callus formation. And he clearly demonstrated not only in our animal studies, but also demonstrated in patients that it works well. Not only that builds much faster callus and they stay less in the frame, of course, the pediatric patients, but also they have less complications and less pain. And you can make patient, whether it's a child or an adult patient, to walk on the frame when it's very painful, and that's what it does. So again, little micromotion, you change it to more rigid fixation, and that we need to still to work it out, and I'll show it to you. So we call this reverse dynamization, not because it's true dynamization that we saw, because that concept is law, it's because it's the other way around. You provide that axial micromotion first, and then make it too rigid. So it's the opposite of that dynamization, which is flawed in a way, but it's still, we think about this way when we talk about dynamization. So here, so idea is to do 3 to 6 weeks and then change it to more rigid. And as you saw in some of these animal studies, in rats, it wasn't rats, it works really well and demonstrated very clearly if you do the wrong way, opposite mechanics, it actually could be very detrimental to that bone healing, so you don't want to do that. Then, of course, we first, as a scientist, as much as we don't like it, we can't test it in the patient, so all of our principles and concepts, we usually use it in animals, start with rats because they're cheap, then we move it to larger animal model, and that's what we did. And actually, Alex and group and Mike, actually, who knows Samchukov, they found me, and then we decided they already started the study using that static and dynamic fixation, and then he said why we just had that group, and he kind of showed it a little bit, and this is what we found. So I wanted to, he showed some graph that I want you to see more from high resolution micro CT, what happens, because you can't see that on the X-ray, what happens with the bone. So this was 1 millimeter osteotomy, and as you can see it here, that's your traditional static, basically that static frame that you have, whether it's fractured. So this was 1 millimeter osteotomy. And as you can see, it actually did pretty good. But again, it has that trabeculation in the cortices. And you know, if you maybe remove that frame or any other implant, it might fail here. Now, when we allow to dynamize it for an entire period of time, which was 8 weeks, look what happens. It builds much more callus, or actually has that bigger callus. And as you can see it here, it keeps it's still, there's a lot of holes here, which is that means, you know, again, you remove the frame and probably gonna fail. Now look what happens when we reverse dynamize it. Again, that dynamization, it means very little when we think about it from the literature, but if you think about that axial movement that is like a spring-like, it returns and comes back, and then you make it rigid, doesn't allow for that. That's what happens. You see these cortices, and you know, that's what we wanna do. When we do it in animal models, we start with this, we try different ways and see what turns out the best. And as you can see, there is no argument here that making it more rigid after you form that callus, it's actually the most efficient way to accelerate that remodeling process, because that's all it does. And the way it does it, it basically prevents that vascular disruption. You have these capillaries, all vessels that move in, and it just doesn't allow that disruption if you think about it. And if you don't have those vessels and you keep not allowing them properly to form, then there is no bone. So that's why it sits around, that's why hypertrophic non-union sits around and they don't heal until you stabilize it and make it really more rigid. So here, that's just from close-up, as you can see. Now here, so again, it's a concept, and we wanted to see if that would apply to distraction osteogenesis. What if we allow actually, do it the classic way that we always do, just allow that static, static lengthening that we always do, Lazaro way or whatnot. What if we allow a little micromotion and allow it for entire time? If we allow that movement, would it be okay? And what if we only allow that micromotion during distraction and then we make it more rigid, as I talked there about osteotomy? And here's what we get. And of course, it's biology. You can be against it, but you can't prove it. And you see it clearly that if you have static, you don't have, when you start to statically lengthen it, you don't see anything there yet. It's probably there, but you can't see it, right? But already by like 2 weeks or even 4 weeks, as you can see, you get pretty big when you allow that little micromotion, not micromotion, I guess change it to axial motion. You start to see that much bigger callus formation, and it is bigger than in the static fixation. It doesn't work. Oops. So then what we did, we actually kept that one group static. Then we had a dynamic group that we, again, allowed that constant movement, and then we reverse dynamize it, which is make it into a static. And this is what happens, and as you can see it clearly, you still have all these like little lines, which is if you look really close, and I'll show you in a second, histologically, again, you can't do that in the patients, there's a bunch of cartilage still there, right? And if you reverse dynamize it, basically make it more rigid, as I said, once you prevent that disruption, that vessel disruption, and you provide all that blood supply, which brings nutrients, it starts to remodel really fast. And here you can see it close up. There is no argument here that this is much better, and I can show you from a really high point of view. Again, it's very difficult to do this in the patients, but when you can see it here, this is your classic Lazaro method. And if you look at it, and they have beautiful images. I actually was lucky enough to visit Kurgan, and they have beautiful images from histology and all you can't see it on the x-rays, but you see this type of, again, all your bone that is growing aligned in that direction of loading, right? Because you push it, basically pull it apart. But what would happen, you think about it, what would happen if you knew, and you often can't do a CT scan on the patient, you just base it on the x-ray, what would happen if you now remove that frame and let that patient walk around? Arguably, you see a lot of these holes. I think if it's a little heavier patient, you probably would fail, right? And you would have a fracture through that regenerate, and you don't want to do that. You want to make sure to accelerate it. Now, when we constantly dynamize it again, it's not too good because, again, it creates too much strains and you have that cartilaginous tissue remaining. Now, when you reverse dynamize it, when you don't allow that movement, as you can see, you get that more solid cortices. It's not done because you have to realize we allowed it only for 2 weeks. Sorry, not 2 weeks, for I think 8 weeks, yeah. And again, there is no argument when you look at really close-up micro-CT, and this is high-resolution 20 micro-CT in 3D, you can see that that's definitely the closest to this one. So you cannot take that argument that it's, oh yeah, we just will do classic and that's the best way to heal bone. It is, and you probably get there, but do you want to do it faster? Do you want to make sure that you can remove that frame, if it's a precise nail, you can remove that nail and get that faster healing outcome and remodeling outcome than you want. Here's histological evidence. Again, you see a lot of these holes. Again, I would not trust it if I was not that I'm a surgeon, but if I was a surgeon, even in animals, I would not remove that frame yet because I would want more solid that cortices consolidation. Here again, these blue and these red lines is a bit more this fibrotic kind of tissue trying to convert, but it's unable to do it because it's too much micromotion. And here, it's pretty solid. You can still see, even though you can't see it on the x-ray, but you can still see a little bit of that cartilaginous tissue, and that blues means like it's kind of converting into woven bone. But there is no argument, again, that if you remove frame here, you probably will be okay, because the cortices are pretty solid. So when does it happen clinically? You can see it like a great example right here. And that's the same principle. Here you have that callus, it's not consolidating, waiting around, it's probably 9 months. And again, the goal is for me, when I started this project, don't wait for 9 months. It's silly. And if you pay attention to non-unions, to these hypertrophic non-unions, you should watch it. You see it at 3 months, that hypertrophic non-union, you can wait all you want. And why waste time? I would go right away and intervene. Why struggle and why make patients struggle? Because it's probably gonna be painful, so why wait? You see it by 3 months, it's probably not doing anything and sitting around. I guarantee you, if you intervene early, you would have better outcomes and happier patient. Here, it's a great example of that reverse dynamization. Put lag screws, and my previous talk, what did it say? In that perpendicular direction of that fracture line, right? You put it, it compresses that fracture, which just means it reduces all the strains. Look what happens 3 weeks later, this is what happens. And you have another one 6 weeks later, it's like magic, it completely remodels. Again, you can't see, this you can see really well here. But look how big that callus is, not because it made it more, it's because it started to remodel. So instead of having cartilage now, you see that like hypertrophy and calcifying cartilage and woven bone, so you can see it on the X-ray. So can you do this now in the clinic? Do we have tools to do it in the clinic? Can we optimize this in such a way that we can actually don't have to do a secondary intervention, don't have to change anything? With a frame, it's easy. But you can't do it now with a nail and a plate technically in vivo patient because we don't have those tools. But you can. You actually can do it with precise nail. And there's a biphasic plate. I think it's only available in Europe. It's very new. There are some flaws within the plate because it makes the system so rigid that it's actually, I'm not so sure it's very good. So the jury is still out. And of course, you can always do it with a frame because you can change the frame the way you want to based on the configurations. Again, you have to be careful because depending how you change that frame, just taking apart, it's just not gonna make you any better. So here's a perfect clinical case that it was fixed not properly, ended up in non-union, fell apart, pins pulled out. It was exchanged for a precise nail for 2 weeks. So it wasn't compressed really hard, you just kind of allowed that movement within that nail. Because it's a nail and it's round, so it most likely would move in that unit, and that's what it did. And after those 2 weeks, 2 millimeter compression. It's basically active stiffening, because people don't like that name reverse dynamization, and I use it only to just demonstrate that it's the opposite way. But you can call it active stiffening, because that's exactly what it is in the process. And as you can see it here, nicely healed, and very fast. That's all it took. It took like basically 2 weeks and then another 2 weeks for consolidation. Of course, is it done healing? Probably not, but it's on the way to heal, and you can see that big callus formation. Here's another, it was gunshot wound. Patient did not want to do mescale or secondary surgeries or anything else. He wanted like one-go surgery and make sure that it works. So it was initially fixed with a standard nail. It didn't work out. Then it was exchanged for precise nail. And again, the same system. You can see 4 weeks later, you can see pretty big callus. It needs some more time, of course, but it's fast remodeling, and you can achieve really good healing. So here I always say, you can't change biology. You're always gonna have, when your bone heals, you're always gonna have hematoma formation, that inflammation phase, granulation tissue that you have like 100% strain because there's nothing there to hold. Then you end up with a soft callus formation, which is that initial callus, and as it starts to calcify, you start to see on the X-ray. And then hard callus formation. And you're always gonna have those phases. Now, what we're trying to do here is to shift those phases. So you actually have much shorter, that soft callus phase, and you have that quicker, harder, that hard tissue remodeling, so that way your patient is happy and everybody's happy. So you accelerate that healing. And from our studies, we can see, especially in all these osteotomies, that you can basically heal those bones about 50% faster, maybe 40 to 50% faster. And that's a big achievement. Imagine if it was you would want as fastest way possible to heal. So I think that's the goal. And of course, the bones would always heal. So of course, the future studies would have to, we have to try, and that's why, as Alex said, they're not applying yet that reverse dynamization, that more rigid fixation in their patients, because we don't know exactly how to make it more stiff and what is stiff enough, right? So we want to find that optimal way, how much we need to do micromotions, and then want to switch it. So we want to know that magnitude. Of course, there is always the timing. Again, as I mentioned in my previous talk, the timing is very important because you don't want to do it too long because you delay everything. Like non-unions, hypertrophic non-unions. If you waiting for 9 months, not going to improve anything. You're just waiting out. And why? You need to fix it faster. So timing is very important in terms of bone healing because it follows specific phases and you want to do it fast because if you have a perfect, just simple fracture, it actually heals quite fast if you fix it, whether it's a plate or a nail. Of course, there are some patients that we have that they can't walk around, right? They're not mobile. So there is also techniques. And I was surprised that Alex actually didn't show. They have this pneumatic device that when patient cannot walk, they apply the dynamic, like that motion, axial motion, because you have to, again, if patients cannot walk around, they cannot heal. So you have to somehow provide that micromotion environment or that, movement within the fracture because it would never heal. Of course, we have to find out whether it's smokers or non-smokers to see any metabolic conditions, how much we need, because I guarantee you, if you have osteoporotic patient, that micromotion would be probably less. Because if you think about any fracture in osteoporotic patients, you often need to double plate it or do a bit more rigid fixation because bone is faulty, as I mentioned also in my talk. So we still have to figure out. And of course, already some companies they have nitinol nails and they're working to see if they can change actually smart devices that they can actually build the callus and then you take an x-ray and you can actually change that stiffness. And you can do now with a precise nail, but it should be better and I'm sure the technology is coming, we just have to wait. So again, think about it when you think about dynamization and really that axial movement. So you either make it more rigid once you basically make that collapse, or you allow for that nice spring return motion. So that's what you have to think about. And that is what is good, that elastic motion. And then later that axial collapse, that's what is actually good. And I guess terminology is kind of used in such a way that it's actually confusing. And that's why in the literature it's very confusing. So we don't understand what is what. That's why some studies are good and some studies are bad and some studies don't find any difference when they do dynamization. So I think you have to be smart about it and you're lucky enough to be here and listen to all these great speakers, whether we agree or disagree, I think you have to think about it for yourself. You have to take everything in and decide and try to apply it and you will learn as you go when you treat your patients. So here now I want to switch gears a little bit. That's my new topic on the project and I would like to educate you about biologics. And as you know, there's really no good biologics on the market. They kind of bone substitutes. I would not call them healers except for some of them. So we have lots of complex fractures and of course managing them, it's very difficult and we have lots of options and the selection of these options depends on each surgeon and whether they choose right or wrong, it's difficult to say. I guess if you choose something, and it works once and you will try to use it again. So those all current treatment options could be better. They're not very sufficient, could be better because they have lots of complications. And once we have to treat these patients specifically with these large segmental defects, then of course it causes not only patient burden because nobody wants to walk around for 2 years or 3 years non-healing. It's also economic burden because they have to be off work and all the expenses to the healthcare system. So we want to do. As much as we don't like it, actually, bone morphogenetic protein, which is sold as a product infused by Medtronic, it's really the best biologic so far, except that we don't know how to use it. And we use such a large doses that it causes so many side effects that it's not really used. And I'm sure most of you in the room, some of you used it before, but you've given up on it because it doesn't work. It doesn't feel like it works because it works similarly as your autograft bone, like Ivaria or whatever, Ilea crest. And that's what studies say. There is no really differential, difference between using one or the other. But what they do find that the side effects are significantly less when you use patient's graft. So unless you're a spine surgeon or maybe a dentist, you probably don't like to use it. And plus it's so expensive. I mean, that large kit with the 12 milligrams, unless you work in some private hospital for the most part in the US, there are certain hospitals can use it at Liberty as much as they want. But certain places in the public settings you don't allow because that 12 milligram dose costs like about $9,000. So it's quite expensive and it's not really efficacious. So why not use a patient's graft, right? So here there is the problem, and you're not scientists or biologists, just look at the shapes. There's probably hundreds of biomaterials that were designed and tested in rats, and we have to do it because it's cheap initially to deliver better BMP2, because current BMP2 is delivered on a sponge, which is actually was designed to do it for your skin. So when I started thinking about 7 years ago, I would go to these biomaterial meetings because I was interested about BMP2 a long time ago. And in fact, I did a study for Medtronic to see if the biologic activity of that growth factor would be affected in the presence of antibiotics, because often surgeons have to, especially in the spine, they have to add antibiotics because it's these type of injuries or spine treatments result in lots of infections. So I look at the scaffold and look at the architecture, and the question I had, actually, do we know what the fracture hematoma looks like? And I have a teaser, actually, this is what it looks like. And we did not know then 7 years ago when I did. And perhaps these architectural properties that attracts these cells and makes it better, maybe that's what's important and not all these scaffolds. Besides, every single scaffold that probably is used to go to conferences, they designed to be at the end of the bone healing. Because every single biomaterial, for the most part, that is made to be cortical bone. But we don't start it with a cortical bone. We started with hematoma. It's a simple way to start. It's very flexible, very gelatinous tissue. So what do we know actually about fracture hematoma? It's actually rich in platelets, very important. Activated platelets release growth factors, because every platelet that has, the more you have, of course, but you have these platelets and PRPs, I'm sure you've heard, being treated, which doesn't quite work, but they have all these receptors for growth factors, and they get activated in the event of injury. Of course, it initiates that acute inflammatory response, which is really needed because all these inflammation genes get activated and thus becomes a template of callus formation, as I spoke in my first talk. So it depends on that, how much that axial motion you provide, that's basically your template, what your callus would look. So you provide a lot, it would expand in the periphery a lot. And if you have a rigid fixation, you would not have that callus formation. So it's very important to think about it in that way. Of course, it serves as a reservoir for growth factors and allows that cell infiltration because it's a porous scaffold to initiate that healing response. It is also a guiding structure for ingrowth of these vessels. And again, you think about it, it is, because cartilage is a bit more porous if you look at microscopically, but it's a bit more solid tissue, like more like cortical. So you need that porosity for blood vessels to go in and actually to bring that oxygen and nutrients so that bone can remodel and heal. And we also know, and then there's quite a few studies, that if you remove that hematoma, actually it delays healing. But to me, I don't think about it as it delays, because it doesn't really delay. If you remove it, that means you basically have to start all over. So it's not really delaying. It delays the overall healing process, but it's not really delaying because it has to restart. There's also some studies to suggest that actually that fracture hematoma, secondary fracture hematoma that forms, is not quite the same. So it lacks some sort of biologic activity. So that's my question was, do we know what it looks like? And actually, I created a model, again in rats, because you have to do it. You can't afford to do it. You can't do it in a patient, so you have to do it somewhere. And you can see if you have normal healing, delayed healing, and non-healing, it's completely different. And the way we control that, we just made bigger gap each time. So this one is like 0.5 millimeter in this model, and it heals normally. It creates little callus, because clearly there's little micromotion. This is bigger, and this is even bigger. And that's a non-healing defect, and that would be a segmental bone defect in this specific model that we heal. And as you can see, there's a difference in fibrin fibers and that big porosity that you have here comparatively. So my idea was, can we create externally something so then it resembles this normally healing fracture hematoma? Because what I'm not saying here too, because I don't want to overload you, we looked also at the RNA sequencing, which is basically looking at the genes, what type of genes are expressed within these hematomas. And there is, of course, with the normal healing, lots of osteogenic factors, inflammatory factors that's good for bone healing. And some of these actually hypoxia-related factors because it's delayed. So it's less oxygen there, so you have this more hypoxic environment because it's cartilaginous tissue. And here, you just have a bunch of fibrotic tissue. So here what we did, we created this biomimetic hematoma, and I call it biomimetic because it mimics, it's biomimicry, so we resemble that normally healing fracture hematoma. And if you vary concentrations of coagulants, you can make it in that way. So here was hypothesis that biomimetic hematoma mimicking naturally healing fracture hematoma would enhance bone healing when combined with a dramatically lower dose BMP2, because remember we want to lower it because it's too much and causes lots of side effects. And that's what we did. And here's my solution. We have a segmental defect, and it's the first autologous scaffold. We have segmental defect. We draw a little blood from the patient. We actually mix it with some compounds, which is calcium and thrombin. And if you think about it, you can say it's just coagulants, but they're very important in that clot formation and activating cell response. So recruiting these cells, it's chemotactic, we call it. So when basically these chemical compounds in the body recruits all the cells to move into area and start the repair process. If we provide it, they all come there, but if you provide the wrong environment, it's probably gonna be non-union because it would form different type of tissues, but they come there. So we just have to make sure that we're smart enough to provide proper environment. So here we created so to resemble that fracture hematoma, and the good part of it is it comes initially as a liquid, so you can make it in any shape and size and form, so you can match the anatomy based on it. You implant it, and it takes 6 to 14 weeks, and it heals. So here, again, is the MACE. There's a lot of bone substitutes. Lots of companies make it BMAX, all kinds of stuff, allograft. And every company every year comes out that, allograft is so much better because we have a specific way of processing. And it really isn't. They're still just bone fillers when you think about it because they don't have that osteoinductivity that you need. So we compare with Medtronic, and we look at the Medtronics. They have BMP2, which is potent inducer of osteogenesis, but they have a sponge. So they deliver on a sponge. And we deliver in the more gelatinous scaffold. So what happens when you have a sponge? Everybody done dishes and have a sponge in the kitchen. You squeeze it, it goes everywhere. And when it goes everywhere in the kitchen, it's okay, it's in the sink, but if it goes everywhere in the body, that's where you start to see ectopic bone formation, lots of different side effects. That's why it was forbidden to start to use in cervical spine because people get started paralyzed because you compresses your spinal cord because bone goes in the places where it's not supposed to go. So here, artificial scaffold, we have autologous scaffold, actually, which is good because we don't want to cause that inflammatory response. Poor bone healing, and it is, because again, not only that it leaks out, it's counterproductive when you have something you deliver and then it just starts to leak out and doesn't contain within it because you want to keep it in place to initiate that healing. Reliable and effective healing. Extremely high doses, we can use significantly low doses. Rapidly leaches away, as I said, you squeeze it, it goes away, where this one is kind of contained within it. Oops. Many deleterious side effects, and it starts initially not only just a bone overgrowth. If you ever use BMP2, there's a lot of reports in the literature from the surgeons that I actually work with, and they use it. They said you initially, 2 days later, so within 72 hours, you had this massive inflammatory response that you basically have that swelling, redness, and sterile seroma that leaks out, which is immediately you think, okay, it's maybe infection, to think about it. And the leg gets hot and patients uncomfortable. They use it, military surgeons, because I'm in a military town in San Antonio, we have Air Force and Army, and the military surgeons, they have lots of affected Army men that they have to use it, and they use it in craniofacial applications. And apparently when they use it, even the smallest dose, creates such a bad inflammatory reaction that their heads blow up like 4 to 5 times. So imagine your skin and everything swells so much and causes so much pain. The face is black and blue, so why would you want to do it? So we have to have a better way to treat it because it is one of the best biologics. So it's the best bone-forming gene and growth factor that you can imagine. So we win comparatively to because there is nothing else. So here, of course, we have to prove it. We have to prove it in cells first, then rats, then we move to larger animals, and here's what we found. And I know most of you can read it. What we found is if you look at that graph, there's a titrated response, so you don't want to have too much calcium. Thrombin is not so important, but calcium is very important because it kills the cell, so you don't want to have too much. Moderation as everything else in life is good, so you don't want to have it too much. Thrombin is good because it makes that clot mechanically more stable. Here, you probably, it looks like gibberish to you, but the only thing you have to look at it, red. The more red, the better it is, because it means it's mineralizing. So that's all you have to think. So here we add just alone BMP2, we have osteogenic media, which just means it has some cocktail of media that has like osteogenic potential for these cells too. So with BMP2, you don't have much red. You have calcium and thrombin alone, you already have much more red than you can imagine, so it means it's gonna mineralize. And then if you have a combination of three, it gets that synergistic and really good response to it. So you wanna have probably all three to enhance that healing. Now, we wanted to see if it works in animals, because cell cultures, again, you can't trust it because it often works differently in animals. So here we did it, the same dose, so this model, specific model, when the BMP2 got developed, they were using about 11 milligrams. That would be the highest dose available for the patient. That would be equivalent to that 12 milligram. So we lowered this to 0.55. And if you do infuse, it doesn't heal. So the only time this heals, if you have at least about 5 micrograms. And here, when you say micrograms and milligrams, it's kind of the same because it's small animal model. It's the same in patients so you don't have to think about units much. But here, and as you can see, really nice bone formation. Still, there's a lot of trabeculation, which is a transient phase of bone healing, but it's okay. And this is a segmental defect that would never heal spontaneously. Then, of course, we had to test it in bigger model, and that is, as you can see, 2.5 centimeter defect. If you don't add anything, it doesn't heal after 8 weeks. If you do infuse, and this is 2.1 milligrams. So that's the lowest dose that would heal in this specific model, 2.1 milligrams. So that's, again, it's more like humans you can compare, so it goes to milligrams. And here we use 20 times less. And as you can see, it's much better. It's much more that more compact bone, and it heals better. And not only, it has much faster healing and has no side effects. Because clearly you can see that remodeling happens much faster afterwards. So of course, lucky enough, we can test it in 50 patients. So we already tested in 50 patients today for safety and efficacy. So we look at here. So what we found is that it's basically that biomimetic hematoma, it's the only carrier, an autologous carrier, that it's able actually to efficiently to deliver this growth factor, which is really potent and good, we just did not know how to use it, with significantly less dosage and no side effects. So here, one case, that was a 5 centimeter defect. It was a mesculae membrane before because it was infected. We added that biomimetic hematoma. 14 weeks later, you can see healing, and this is a CT scan. It bridged. The tricky part was for this specific case that BMP2 could not be used because it was public hospital and they couldn't use it. So, but it worked, and I think the reason it worked, we're still trying to figure out why this specific case worked, but I think the reason it worked because it had a mesculae membrane. Because mesculae membrane works as if it was that neoperiostem they are formed on that covers that sheath of bone. So here, of course, it was a 23-year-old patient, but he healed really fast. After 5 months, he was healed, and it was much faster than normally could. And you have to appreciate that it was a large defect. I think it was 5 centimeter defect here. So then here, this is my favorite case. This is a lady was golfing in Australia. She's 82, was at the time of golfing. Somebody ran over her with a golf cart. Bad accident. She had 3B open tibial fracture. She was 8 months in the TSF, talar special frame. And after 9 or 10 months, she was non-union. They tried to do something else, adjust the frame and do all kinds of stuff. It still was a non-union. So then her wounds started to open where initially penetrated skin, and plastics were called in to cover. And when plastics came in, they always, you probably know, do ultrasound. And what they found is she had one vessel leg and pretty poor quality bone. So they said, there's no point of putting a graft because she's not going to heal and she needs to be amputated. And other surgeons agreed and so on. So luckily, I was working with one of the surgeons who is against all the rules. And he said, no, and he knew my research and said, no, we should try something else. And he proposed to the lady. So once we got in, instead of being a just simple non-union, he found that he had to really resect a bunch of bone because it was dead already after those 10 months. And as you can imagine, 82, so it's hard to heal these patients. So she ended up with 3.5 centimeter defect. So we made this biomimetic hematoma clot, we put it in, and actually happy, not to my surprise, but a lot of surgeons' surprise because they didn't believe in it. 6 weeks later, you can start to see her bridging, and that was AP and AP lateral, and then finally C after 14 weeks. And here she is 5 months after the surgery. She's walking around without even a walker. So she was successful, and she was actually basically said, you have to amputate her. So imagine she's 83 now, and she's walking around, she's happy, and by now I think that was about a month ago, so she's probably returned to golf, playing golf. So here we did this at Cedars-Sinai. Again, 88 patient did not heal for a long time, and here's what happened. We put it biomimetic hematoma. It was 10 cc's to fuse her ankle because it was not healing. And as you can see, 2 months later, we have a really nice healing there. Of course, it needs to heal more, but it's very fast comparatively, especially in the old patient. Again, we used it for docking site, and again, some argue that, oh yeah, but you did compression, but they tried everything. They tried autograft bone and didn't work, so we put it biomimetic hematoma, it works. So here, quick summary. The biomimetic hematoma delivers an extremely low of BMP2, which consistently and robustly can initiate healing, and we've shown that also in the patients. Healing outcomes in BH group were much superior. The ex vivo hematoma mimics that function of normally healing fracture hematoma because it's really able to fake your body and really think that it's your normal fracture hematoma that would form. Provides a favorable environment for cell infiltration because he has all the holes and all porosity that you need. And my indication was not only, to avoid, because these talks are how to avoid non-unions, to use it as a primary specifically for open tibial fractures because you improve it. Of course, you can use it for delayed non-unions and segmental defects because that would heal, especially segmental defects because that's a completely different animal. So here how it works. It's very simple. It takes 15 minutes to make before you can implant in the patient. So we start about 30 minutes before. You take, as you saw, take some blood, let it sit 15 minutes. You take it out and it looks like, those who in America and been to America and participated in Thanksgiving, it looks like a cranberry sauce almost. It's really a blood clot like this, and you implant it and actually heal the bone. And then acknowledgements to all my collaborators, and thank you for your attention.